So I thought what I'd do just at the beginning is really to put the work of SCI that you're going to hear a lot about this evening into a bigger context and into really the global development context. Now, since we were all here last year, a lot has changed. Actually, almost exactly a year ago, in September 2015, the UN adopted the Sustainable Development Goals. Now, these aimed to replace and extend the Millennium Development Goals that were launched in 2000 running through to 2015, that really aimed to accelerate progress in many areas of development, and arguably probably are the most effective to date at unifying a global community around a truly global set of common targets. The SDGs set out 17 goals that you can see here that really span economic, social and environmental dimensions. And they were much bolder than their predecessors, the Millennium Development Goals. By 2030, they aim to They aim to end hunger rather than ceasing to reduce poverty, and rather than promoting gender equality, they aim for complete gender equity. So, and in the health sphere, rather than identifying specific areas for improvement, such as maternal health and combating a defined number of diseases, they really aim for a much more universal healthcare. So ensuring that the people that need healthcare receive it when they need it, where they need it, and at a cost that they can afford. So these goals really are much more about achieving global equity to opportunity, and have also been seen as a pledge to leave no one behind. So who are we most likely to leave behind, and how can we ensure that we reach those unreached? Clearly, those who are economically disadvantaged are the very poorest of the poor are most likely to be left behind. And the maps I'm going to show you illustrate this economic disadvantage. But these maps, rather than showing the size of the country dependent on the land mass, which is what we're used to seeing in maps, these... Oh, okay, sorry. I'm really sorry. I just need to... I think this... Sorry, the... Okay, that's disappointing. However, the maps that I was going to show you, they were going to illustrate that the areas where people are living at $2 a day are obviously hugely expanded in sub-Saharan Africa and in India, and obviously the areas where people are earning over $200 a day, Africa completely disappears, and obviously America and Europe dominate the map. So sorry, they're quite fun to look at, but anyway. But I think it's kind of worth reflecting that in the countries that have the largest populations living in extreme poverty are those that often have large and growing economies, and obviously India is an example of that. And this graph is actually looking at African economies, and this really illustrates the growth over the last 2 decades. And firstly, the size of the bubble illustrates the GDP of the country. So you can see that places like Nigeria have large GDPs, and all these economies are still growing. In the last 5 years, compared to the previous decade, Nigeria's growth has decelerated, but it's still a growing economy. There's other economies such as DRC and Ethiopia and Cote d'Ivoire that are, in the last 5 years, have continued to grow at an accelerated rate. So even when countries' GDP is increasing, it doesn't guarantee that the reduction in those living in extreme poverty. So And the estimates, some estimates suggest that over half the people that live in extreme poverty are within middle income countries. So we have to think really carefully about, so this is the map that you were going to see there at the top. So you can see that that sub-Saharan Africa is enormous, and so is India, and this illustrates the size of the country represents the number of people in that country that are living at less than $2 a day. So this is extremely important when we consider the distribution of NTDs. And you can just see visually here, and this shows you the prevalence of schistosomiasis here on the left and the prevalence of soil transmitted here on the right. And the darker the colour is, the higher the prevalence of those diseases in those countries. So you can see that that these diseases are most prevalent in populations living on less than $2 a day. And so NTDs are increasingly being used as a tracer for poverty. And as we know, NTDs are both a cause of poverty, with their disabling symptoms reducing children's ability to learn and develop, and ultimately to contribute to productivity in their communities. But also, they are a consequence of poverty and thrive in conditions of poor water and sanitation and of lack of access to health. And if we look here at some WHO figures, so looking at the number of people that are requiring an intervention for any of the NTDs, looked at by World Bank Income Group, you can see that the greatest number of people, so 1.1 billion people that are requiring treatment against NTDs, actually live in middle income countries. So to ensure that we leave no one behind, we really need to think very carefully about how globally we distribute our resources. When we also see an overlap with NTDs in areas of gender equality, and this is a map put together by the World Economic Forum looking at the gender gap, and the darker, and again I apologise, the legend hasn't come out, the darker the colour, the better the gender equality. And in the areas in white is the poorest, and the areas in grey are those where there is no data available, which makes one think that perhaps in those areas they may be in fact whiter than white, which in this circumstance is not a good thing. So this highlights another group that are likely to be disadvantaged, and you will hear from colleagues later on about how SCI is trying to target and make sure that our treatments reach all genders. But we're also starting to look at gender issues more broadly, because many of our drug distributors and community health workers who you'll hear about are women, and indeed frequently show better performance in their activities. And perhaps this may seem like a good thing. But when we start looking at the unintended consequences of those and the impact on their ability to fulfill other commitments and look after their families, that actually this may be an increasing area that we need to look at and support these people within their communities. Also, the majority of our programs that you'll hear about target schools as a way of reaching children in the most effective way possible. However, we are all aware that a large number of children don't attend school. And you can see here, this graph shows the number of children in the dotted circles who were out of school in 2000, and in the coloured hard-edged circles, they were out of school in 2013. And these were put together by UNICEF. So we can see that there's a significant drop over time in a number of areas, which is very encouraging. But when you look at the figure in green, you can see that still 33 million children in sub-Saharan Africa are out of school. So we really need to think carefully how we ensure that we reach those children that don't attend school. We're obviously all aware that conflict has devastating effects on for generations, and as sometimes a group as sometimes it's impossible to reach many people affected in these conflict countries. We do currently have a program in Yemen, but unfortunately our remarkable program manager there has had to be evacuated out to Egypt following the unrests there. So in order to make sure that we are reaching the unreachable, we really need to focus on these groups. And as I said, you will hear more about that later on this evening. But I think that it's recognised globally how important NTDs are as a tracer and also a way of ensuring that we reach these really underserved and vulnerable populations. And this is reflected that actually within the Sustainable Development Goal 3, there is actually a specific target for neglected tropical diseases, which is very important. So SCI, as you can see in your handout, SCI does target countries that do where a large number of people live in extreme poverty. We are increasing the number of treatments, the number of countries that we reach. And again, you will see, to illustrate, in 2013, we had a significant reduction in the number of treatments, and that was potentially because of the unrest in Yemen that did not allow us to reach many participants there. So SCI obviously doesn't work independently. We have a huge network of partners, and we work very closely with the WHO. And this is the WHO global figures from 2006 to 2014 that shows in 2014, that is the latest data set that's available, 62 million treatments for schistosomiasis was reported. That sounds impressive, but when we realise that there are just under 300 million people that need treatment, we see that in 2014 we only reached just over 20% of those people in need of treatment. SCI, you can see here in the light bars, this is the percentage of, this is the number of treatments that SCI has delivered in relation to the global treatment figures, and you can see that about a quarter of all the globally, all the treatments of all ages are delivered by SCI. And if you look only at school-age children and only at Africa, that number increases significantly. We're also very fortunate that we are supported by another partner, Merck, who donate praziquantel, which is the drug that we use to treat schistosomiasis. And in 2015, they donated 100 million treatments, and that is set to increase to 250 million. We're also working in partnership with a consortium that are developing a paediatric compound so that we can safely treat children under 5. And I know that we have a member of that consortium here who I'm sure will be able to answer questions later on. So although we have this enormous resource in the donated praziquantel, there's still some gaps. And this is a figure recently produced by WHO, and the total need for 285 million people, you can see there in the purple line. The green triangles show the total available. So that's the donated praziquantel and also that's purchased by other organisations. And you can see that there's a significant gap there. And this really is an imperative for SCI to support resource mobilisation so that we can ensure that the praziquantel that is available is delivered, and that we advocate so that we can fill that gap in the future. So that's all I'm going to say now, and I'd like to just pass on to members of our implementation team who are going to tell you in more detail how our programmes run.